Dave Ty's running the tube. Oh my gosh. See how it is, Mr. Choi. Good luck in your exam. That's good. Okay, perfect. Hello. Thank you for coming. And I understand there are people watching the recording as well. My name is David. I'm in 4th year. So I did my phase 1 2 years ago. Firstly, how are people feeling about OSCEs at the moment? Good? Bad? Too far away to think about it? Bad. Why? What are you feeling bad about in particular? Like, just...
So I listened to her class the other day. If you haven't been practicing,
if you haven't been practicing, go back to first year now. Kind of rough. Yeah. Well, look, I guess I wanted to start off with my general advice about phase 1 OSCEs before diving into gastro stuff. Now, sorry, that's my notes. Okay. I will say the practicing is actually quite important, and that's probably the biggest thing the biggest tip that I can give. See you, Dom. Practicing? Oh, I'm out. Okay, so yes, the important thing about the phase 1 OSCEs is essentially how you walk into the room and how confident you are doing it. You might have heard advice that it's a bit of a game or a show. That is essentially what it is. If you can walk in there like you've done it 1,000 times before or 1,000,000 times, that really helps. Now, in terms of practicing, I know that can be really stressful because you kind of just finish H&B and you're into last teaching period, and there's prac exam, end of phase, different things. But the biggest thing I can say is 2 hours a week, and that's just based on what I did with my friends in SEM 2 of phase 1. 2 hours a week, we just went through one system week. That was literally all the prep I did up until after prac exam. So then you have like a week's gap between prac exam and end of phase. During that time, I did spent the morning on end of phase and a few hours in the afternoon on OSCEs. So in terms of practicing, I mean, that is the biggest thing I can say that you need to do, but don't stress about it. 2 hours a week is very manageable. And in terms of who you should practice with, phase 1 is the only time where you can get away with just doing fake patients. Some people think, worry about, should I go to hospital or not? I just think in terms of your time, going to hospital is not the best use of time because I remember doing that a few times, but just was never really good phase 1 OSCE practice. I mean, it was great to be in the hospital, see real patients, but I often found that it took ages to find patients. And then when you do it, do you do it timed? Do you not do it timed? If you time it, do you cut the patient off halfway through? It just becomes too logistically unmanageable. So I really think it's just much better to find a couple of your friends. You can book out the clinical skills room or wherever and just go through, one exam a week in terms of preparing for it. The other, kind of general advice, as I said, it is a bit of a show, or it's a show in that you can rehearse kind of what you're going to do beforehand, because that all the patients are going to, they're mostly going to have normal signs or normal findings. You shouldn't feel pressured that you have to pick up a murmur or you have to pick up, you have to feel differentiate between metastasis in the liver versus something else. It's stuff that you can practice beforehand, and I think that should give you confidence because the stuff that you're going to be doing with your friends is exactly what you're going to need to do on the day. But even though it is a show, you still need to think on the day, so you can't go into complete autopilot mode. I just remember because I was a little bit thrown because I kind of had all my things exams and procedures ready to go. But on the day, the way they do the stations is they might ask for only part of an exam, or they might combine a few different procedures. And so if you kind of get too focused on my gastro exam has to start at the hands, and if it doesn't start at the hands, well, I'll just walk out now. If you get into that mindset, it's a little unhelpful. And of course, there are the vivas that they throw at you, so you need to kind of think about why you're doing certain steps. And practice concise histories. I think in the actual OSCE, the histories is probably where you can lose the most time. And I think it's just because everyone gets worried that they're going to miss a key question or, not characterize the symptom enough. But I think, you have lots of different symptoms for all the kind of exams that you will need to learn about. If you can just ask a few characterizing questions for each of those symptoms, that's enough. Don't get stuck into the, asking all these obscure questions about someone's diarrhea or something. If you can just ask the main ones, that's enough. And I suppose a tip for that is if you're in the exam and the patient's starting to say no to all your questions, then you've asked enough. And the examiners will often prompt you to move on. So I recognize you may have been told that before, but I just think that's helpful to reinforce. Perfect. So we're going to go into the gastrointestinal history plus exam. 62-year-old man presents to the GP after an episode of abdominal pain. Please take the man's history, a full abdominal exam, and summarize this case. So I thought for this tute we'd just kind of go through this case as a group. So this is kind of pretty much taken from last year's OSCE. So it's a pretty standard case as well. So I just thought we'd go through it as a group. So what are we going to do? When we get this case, you're outside the room. You've got they've rung the bell. You've got 2 minutes before they've rung the bell from the last case, and you've got 2 minutes before you read, before you actually head into the room. What kind of things are you guys going to do and think about? Anyone?
I mean, for the history, you're probably going to start thinking of the main symptoms
Yep.
that you would want to consider for a gastrointestinal history.
Yep.
So weight loss, weight changes, diarrhea, constipation.
Yep.
Nausea, vomiting.
Yep. And in terms of I suppose the reason why I wanted to ask what do you do is because that 2 minutes before before you head in is kind of golden time. You know what the case is going to be now, and you can just you'll be given a notepad, and you can just kind of write down, just blurt out everything on that page that you want as kind of, memory hints while you're in the actual room. So, yeah, if I saw this, I just exactly write down some of the key history points that I want to ask. Pain, I can just write down Socrates. And then for the abdo exam, just write down the big points that, the big things that you're going to need to do in there. The first thing is, and then you actually knock on the door and you walk into the room. So this is kind of one of the parts that you can rehearse really well, the actual walk into the room and introducing yourself. But don't get too hung up on it. I just remember that before my exam, I practiced it a fair bit, but there are always differences on the day, such as the hand wash is often outside, but then there's another one inside. So you kind of do you do it inside and then walk in as you're washing your hands. So the point is, if you've over-rehearsed it, it'll put you off on the day. Just remember the main things that you need to do. So the first is obviously you wash your hands and you go in. Hi, my name's David, second year medical student, what's your name? And then just explain briefly what you're going to do. I wouldn't go into the physical exam at this point. I wouldn't explain what I'm going to do in the physical exam at this point. Just say that you're there to kind of talk about why they've come in. And then at that point, I would ask how old they are and what they do for a living, just because that's a kind of nice, very short kind of rapport building thing. Now, I've been a kind of mock patient for some the MedSoc mock OSCEs, and sometimes people come in and they start off with can I please have your name and age? And I just find that really kind of stultifying. It really is off-putting when you are kind of a mock patient. So I would avoid going in there like a military kind of commander or something. Just be pretty natural. What's your name? What do you do? Kind of thing. And again, some people worry about, should you write down? Shouldn't you write down? Does that break rapport? I think writing, you'll be given I think most hospitals give you a little notepad to write on. You obviously can't take your own notepad in. It's better to write down someone's name and age than kind of forget it later on. But that's probably the only thing I would write down. Maybe some of their main symptoms, but writing down the name is fine. Writing down the rest of the history, you know, if you're looking down too much, that does affect the report a little bit. Good. Okay then. So the history of presenting complaint, the idea is you always start very open and then move into closed questioning. So that's kind of just the formula I use, what's brought you in, and they'll tell you a little bit, and you know, normal conversation, they'll tell you a little bit, and then, you know, they won't want to feel like they're talking for too long, so then they'll stop, even if they have more to say. So at that point, I'm always like, oh, can you tell me a little bit more? And then they may, or if they say no, that's when you go into your closed questioning. So for the case that we had, so just let me check. So what's the, you know, we've done our introductions, got the consent, washed our hands, done everything, and we get to kind of the meat of the case. So how are we going to approach this? How do you approach someone who's come in with abdominal pain? Yeah, so yeet that Socrates. Socrates, this is kind of a gimme station. Pain, when you see pain, immediately just think Socrates. Write down on your notepad Socrates. So let's go through for a bit, like focusing on an abdominal case. What are some of the things you ask in Socrates? So going around the room.
Point to where.
Point, exactly. And asking them to actually point is a lot easier than asking them to describe generally where it is. Okay, so that's site. Onset, what kind of things are we going to ask?
When did it begin?
Sorry? When did it begin? Yep. And what other things in terms of onset?
Like how long, like, does the pain come and go, or is it constant?
Yeah. That's right. And one other big thing in terms of onset.
Duration.
Ooh, not quite. Well, I mean, that is important.
Is it going worse?
Yep, that's a good one. Something bring up. So is the onset sudden or gradual? And that's really important. So yeah, is it onset? Is it sudden, gradual? When did it begin? What were you doing when it began is sometimes an important question. You know, obviously if someone gets pain in the tummy, it's different if they've you know, just been punched in the stomach versus if they're sleeping. So that's onset. What next? I heard character. Okay, so what kind of things for abdominal pain do we want to ask?
Well, I guess you want to differentiate if it's like an infection-related pain, if it's like dull but like constant and throbbing.
Yeah.
Whether or not they can move around, or whether they're trying to like hold still.
Yep. Yeah, that's right. So what kind of questions would you actually ask? You know, if I've come in, I've just told you, you know, sharp abdominal pain. Oh, you know, I'm just giving you a hint. I've just told you, I just had this pain. It actually woke me up at 3 a.m. And it's kind of here. What do you?
Yeah, I guess like I would try to start with an open question, like, oh, can you describe it a bit for me? And then if they can't, then
Okay.
be like, is it sharp pain?
Yep.
Is it dull and consistent? Does
Yep.
it come and go?
Yep, those are great questions. So yeah, I mean, I'd probably say like, oh, you know, it's sharp pain. You know, I felt it for, and someone asked about progression before, duration, and I'd be like, oh, you know, I felt it for a few hours and then I went back to sleep, kind of thing. Yeah, character. What next? Yeah, exactly. So how would you ask it?
Is like the pain in like one spot, or does it like move around?
Yeah.
Go anywhere else?
Yeah. And what are some kind of common ones that you might come across in a kind of gastro exam?
Appendicitis.
Yeah.
Potentially moving from middle to where the appendix is.
Yeah, good. Appendicitis. I'm thinking of two more. Oh, yeah?
Acute pancreatitis goes to the back.
Yep, very good. Which is, yeah, so kidney-related pathology. So that low to groin ones, I mean, in your phase 1 clinical skills guide, like asking about dysuria is a symptom that it lists. So, you know, expect to be, have to ask about kind of, oh, you know, where does the pain go? Does it kind of you probably wouldn't say loin to groin. You know, does it start around the ribs? Does it kind of move down towards your groin? Something like that. Radiation. Then A for, okay, some people do like associated symptoms, but I think alleviating and exacerbating factors makes a lot more sense here. So what kind of things would you ask?
Anything make it better or worse?
Yep. And if you were to give them like some specific suggestions, like, we kind of have.
Like the time of day, like
Yep.
after a meal,
Yep. After a meal.
after going to the toilet.
Yep. And I think we also had before, like moving around is quite an important one. And also in exacerbating factors, I think like medications, have they done anything for it? You know, if they have kind of epigastric pain and it goes away after they take, you know, Nexium, that kind of gives a good indication. And then timing. So yeah, we mentioned that probably would come out like in the kind of onset, like they'll probably mention, oh, you know, I've had this for days and days, or, you know, I've just had this for a few hours kind of thing. And then severity. So everyone familiar with the out of 10 scale? Yep, all good. So I think I just had a few kind of points about there. Do you feel anywhere else? Oh, yeah. So then after you've done Socrates, that should give you a pretty good idea of, characterizing the pain. And then it's just always good to get a bit more kind of contextual information, ask have they had any other symptoms, and it's always good to throw in the constitutional symptoms, night sweats, weight loss, fever. Good. I will obviously make these slides available after. And then the last two ones in the kind of presenting complaint bracket. Have you had this before, and any ideas of what it might be? Have you had this before is actually quite an important question. I suppose this case, the case ends up being something like acute pancreatitis, which is something, so you're not expected to like diagnose that in the OSCE, but acute pancreatitis is something that comes and goes regularly. So if you're like, have you had this before? And they're like, yeah, like 3 times every time I drink alcohol, like that gives you a pretty good indication. And then of course, any ideas of what it might be. That question you can kind of gauge whether it's, you know, whether it fits in well into kind of the structure of your history or not. All right. So internal summary. So how do people approach internal summaries?
Like I usually try to do like after the presenting complaint and then at the end.
Mm-hmm. Yeah.
Like a small, like little one to make sure that I haven't missed any like big things that they're worried about.
Yeah. Yeah, exactly. So, I mean, the internal summary is just good to do straight after presenting complaint, exactly as Michael said, just to make sure nothing's been missed. So, I kind of did have the case prepared, but we haven't really gone into it much, which is okay. But that's kind of the case from the memorandum. Yeah. Okay, any questions so far? Yes.
Are there any ways of gauging severity other than the 1 to 10 scale?
1 to 10. Are there better ways? Is that what you asked? I would say that the 1 to 10 scale is pretty standard. Like it's pretty reliable. There are other ways. Like, for pediatric patients, they can do like a face chart or different things. But I think the 1 out of 10 is pretty quick and reliable. Have you found that it's kind of hard to ask, or?
Well, no, as in, I think it's easy to ask. I just heard that some doctors just don't like it.
Yeah, I think because Sue said that.
Oh, those two, okay.
Yeah.
Yeah, I couldn't remember who it was. But yeah.
Because like we've been told, like sometimes it's more for just like monitoring pain because it's quite subjective, and like potentially a better one to use is like how it affects their like activities of daily living or like things that they do normally.
Yes, yeah. In terms of properly like characterizing the effect, on someone's life, 100% asking about the activities of daily living. And look, you could definitely throw that in severity. So, if you've gone through the exacerbating symptoms and everything, and then you ask, okay, so what kind of things have stopped you doing? And they say, oh, I'm still walking about fine, versus, yeah, I haven't been out of bed all day. That does make a big difference. I wouldn't go into specific activities daily living, like asking, like, oh, does it affect your work or your sleep? Things that are just kind of more context. The 1 out of 10 obviously is very subjective, and but I think if you ask it in an OSCE, you'll be good. Any other questions about presenting complaint? No? Okay. All good. Is everyone familiar with the term signposting? No? Yes? No? Yeah. Great. Signposting is fantastic. Like, the examiners love it when you do it. So just reinforce. And these are the kind of parts of your history that you can really practice. Okay, thanks for telling me about why you've come in. Just want to ask a little bit more about your past medical history, conditions you've had before, just to get a better idea of what this pain, what might be causing this pain. So, what are some of the things that we ask in past medical history? Yep. So how would you ask it? Yeah, I would probably start even just a little bit more open, like, oh, do you have any other medical conditions? But then, yeah, if they kind of say no, like, you can prompt them with those questions. So yeah, do you have any other medical conditions? They might say yes or no. Often they might say no. In which case, do you guys have prompts for other other important conditions that you might want to ask about, chronic conditions? Yeah, so just go through, like, diabetes, heart problems, kidney problems, asthma, high blood pressure and cholesterol are probably the key ones. What else? What else might be important in past medical history? Yeah, exactly. That gives a great indication. And that captures, like, whether they've had surgery versus, like, emergency department presentations. Anything else in past medical history? I think I'm pretty happy with that. Yeah. All right. Easily forgotten, but please do not forget medications and allergies. I suppose just in this one, or what are some of the things that people ask about, or how do you ask this? Yeah, that's probably the key one. So obviously, it's pretty simple to ask, are you on any medication at the moment? And then, yeah, just to ask over-the-counter, vitamins, supplements, or even, any kind of traditional or herbal medicines you can ask about. And then allergies, the big, like, allergies, just make sure you ask, it can be good just to ask specifically, do you have any allergies to medications? As well as just, like, general bee or nut allergies. Good. So, in terms of the OSCE being a bit of a show, I felt very fake kind of writing this, because it is, but in kind of the world of the Phase 1 OSCE, as I said, it's all a little bit of a show in that you can rehearse it. So, family history is often, when they might say, oh, my parents, one of them died from bowel cancer, or, I suppose they can come up with a number of things. And so it can be helpful just to have them back in your mind, okay, I'm sorry to hear that. And I suppose it'll depend on, like, whether they're still alive or not, and you can kind of get a gauge of, if they're a 70-year-old man and they said, my mum died at the age of 100, like, you can somewhat assume that, it may not be something that's directly affecting them then, but, if they say, my parents have bowel cancer and, I've got this abdominal pain, like, what could it be, kind of thing, That's when you say, oh, I'm really sorry to hear that. That's just why we're asking these questions to, get to the bottom of why we're here. But just ask ask if there's been a history of the specific complaint. Now, obviously, don't just, if someone comes with like abdominal pain, don't ask, oh, has anyone in your family ever had abdominal pain? Because that's not very helpful. But just ask if anyone in your family had any bowel problems or conditions with their bowels. The most common ones are like in terms of that run in families are Crohn's and bowel cancer. And any other general conditions. All right. Psychosocial. So I mentioned before about making the histories concise, because often the phase 1 OSCE is kind of pressed for time. And I think if you find yourself pressed for the time, like in the middle of the history, in kind of like the past medical history and the family history, what you really want to get out is to the psychosocial for that alcohol, smoking and drugs, because that's really important for most exams, like for most body systems, particularly for GIT. I mean, alcohol is a big one, smoking as well, cancer risk, and always any other drugs. In fact, any other drug is really important as well, because if someone is injecting, they can have like hepatitis. Yeah. So, does anyone have a formula for remembering the bits of psychosocial that you ask about? Yeah, okay, so you've been, okay, they do cover, okay. Yeah, so, sorry? Dana. Oh, yeah, fantastic, yeah. So that's exactly what you do. And a lot of, so as I said, yeah, so diet and exercise, home situation, if you're running out of this time, those can be forgotten, just get to the drugs.
Travel something you want to cover?
Sorry?
Is travel something you always want to cover for a gastrointestinal history?
You're exactly right. I haven't included that, but I definitely would. That's very true for things like hepa, typhoid. Might depend a little bit on the symptom. I mean, for someone like vomiting or diarrhea, 100%. Maybe like abdominal pain that's woken them up at 3 a.m. Oh, maybe. But yeah. All right, that's psychosocial. And then you can just do another brief summary and then get to the exam. So for the exam, how do people explain the exam? Just like to give a heads up to the patient. Anyone have a good explanation for the gastro exam?
Like a touch and feel of your belly.
Yeah.
Like
Yeah.
if it's ever painful, let me know and I'll stop.
Yeah. So that's fine. I mean, I suppose everyone has a little different way of doing it. I just talk a little bit about. I just try and make again another line that you can easily rehearse. Just kind of look at hands, face, and then feel your tummy. Is that okay? And they'll always say yes in the phase 1 OSCE. So just some more kind of general advice for the exam. Wash your hands again. I know everyone drills on, but just do it. Reporting back. Okay, what have you guys been told? Not to do it. Sorry? Yes, exactly. So you should not do it, and then you should also do it. Okay. Every year, I don't know why. Well, I do know why, that you get mixed messages. My advice is to practice reporting back and expect to go in there and do it, but you should expect to be told not to do it. In my OSCE, 5 stations, the examiners were happy with it. In the 6th station, I was told not to do it, and that examiner was someone who was actually from the faculty, whereas all the other examiners were like from the hospital, which, yeah. So I would definitely report back unless told otherwise. General observation. So general observation is important, but I think just because of, sometimes the Tute's kind of MedSoc runs, people can get too hung up on it and people get told about stories of like having to look under the bed or behind the door, and you have like students in the exams room just like doing this whole routine. And I think that can be a bit off-putting for both the patient and the examiner. So just be smart about it. I mean, yeah, do give it a bit of a glance, but yeah, I wouldn't go over the top.
I was thinking like around that, and I was just wondering, do you think it's appropriate at the start of the exam, especially if it's something like breast, just to be like, oh, do you use any oxygen or anything like that, or like if you haven't already covered it in the exam, instead of having to
Look around for like an O2. Yeah.
like being like excessively looking around, being like, oh, do you need a walking stick if they ask you to do the like musculoskeletal?
Yeah, I think that's, I mean, the patient is the best source of information, and just because you've finished the history doesn't mean you can't like ask questions kind of thing. Yeah. All right. So I suppose for general observations for the gastro exam, it's pretty, I suppose, straightforward. You can just make a general comment. Patient looks comfortable at rest. They're looking well. Or if they're unwell, again, unlikely in a phase 1 OSCE, but you might be asked to comment on things like, particularly if they're markedly jaundiced, they're breathing heavy, do they kind of look, a bit pale or sallow-faced. And then medical adjuncts as well, again, like things like vomiting bag, NG tubes, catheters, colostomy bags. Really unlikely to get actual pathologies and things like that in phase 1 OSCE, but you never know. So, peripheral signs. Again, what have you been told about peripheral signs?
Looking for a few key ones.
Few key ones. Okay.
Very over the top.
Yes. So in your clinical skills guide, it says, like I was looking at it this morning, it says specifically not to look for peripheral signs. I think it's kind of similar for reporting back. Like, I think you should go in there expecting to do it, but be very prepared for the examiner to just say, oh, just move on to the abdomen, or just move on to, the lungs or whatever. I suppose the point about that is that like it just gets you into good habits, and I think particularly the hospital doctors, often they're used to examining either higher students or even like physician, like postgraduate levels, and they always start with a hand. So, and they'll probably be very used to that and somewhat expecting it. So, go in there expecting to do peripheral signs. But in terms of being like over the top, I probably tended towards the over the top in my phase 1, and I did get tripped up like a couple of times, or like one specific example where I named a sign and the examiner questioned it, and I was like, I kind of remember it from tallies, but like, so if you are going to name something, you have to know what it is you're looking for and why you're looking for it. So let's just go through it briefly. What are some of the peripheral signs that we go for in the gastro exam? Some big ones. Yeah, so starting at the hand, palmar erythema, metabolic flap, if you'd like. Yeah. Again, yeah, clubbing.
Like the canicia.
Yeah, exactly. So why do we look for some of these things? Metabolic flap.
Metabolic flap is related to CO2 retention. Oh, maybe it's ammonia.
Yeah.
It's also mainly due to liver failure. So is the canicia and the palmar erythema is related to excess estrogen.
Pretty much all the peripheral signs in the gastro exam are signs of chronic liver disease. So, yes, palmar erythema due to high levels of estrogen. Asterisk or hepatic flap is due to hepatic encephalopathy, which is due to increased ammonia. I can't remember the mechanism of leukonychia.
Specifically, they kind of just mentioned it with all the estrogen ones.
Yeah. And then some other ones moving up the arms, you can look for bruising due to loss of clotting factors from liver failure. You can look for track marks in terms of IV drug use. And then any in the face. Sclerotic erythema, yeah, that's the key one. Can't miss that. Particularly because, yeah, so if someone's going to be jaundiced, they'll be seen in the eyes before the rest of the body. excuse me, also in the face, conjunctival pallor, that goes across systems as well, just looking for anemia. And then you can also look for supraclavicular node, because that can be a sign of, so an enlarged node can be a sign of gastric cancer. And then any in the chest that people know? Spider nevi, again related to increased estrogen from liver failure. Okay, so if anyone is freaked out because we just like started randomly going on about liver failure and estrogen, don't be. Again, that's peripheral signs. Unlikely that you'll be asked to. I don't think you'll ever be specifically asked to do it. But if you kind of go in there and start with the hands, I think that shows just good practice. But if you're going to be naming them, need to know why they're important. All right, everyone happy with that? Hope I haven't just freaked everyone out because he started talking about. All right, peripheral science. So I've just, okay. Few ones, spider nevi, and gynae. All right, so finally we get to the actual, the money bag. This is the important stuff. So what do we start with? We've gone through everything. We get to the tummy. Exposure, exactly. Now, some people say like you could have exposed them beforehand. There's a bit of an argument, like do you expose someone before and then start looking at their hands? Some people say like, yeah, that's you should keep the patient like with their clothes on until you absolutely have to, and that's probably one of the best ways to do it. So what is the exposure for the abdominal exam? You're pointing at?
Like you want to like expose the ASI,
Mm-hmm.
like at the bottom, and then like as high as you like feel comfortable with.
Yep, exposure. And what about the positioning of the patient? Arms by the side, lying flat, head on the pillow. Good stuff. Okay. And then what's after exposure? Inspection. Right. What are some of the things we're looking for? Yep. And how do you check for swelling? Using your eyes only. Sorry, there's a bit of tripping up. Point is you can't say that someone's abdomen is distended or swollen unless you're like looking from the side. So this is one where you do have to do a bit of acrobatics, so to speak. But yeah, if you're just looking at it from the top and then you say, oh, it's distended, the examiner may say, may ask you how you know that. So if you're looking for distension, you kind of have to get at the patient's level and look from the side.
But with that, like
Yeah.
how, because you only later know, like if it's just like fat or like fluid, or like is there a way to tell, like other than, if it's like rigid, is fluid?
Oh, like if you're just looking at someone's abdomen, how do you tell whether it's like they're obese or whether they're like have ascites? I suppose once you, I mean, obviously later on, yes, it's once you get to the percussion. Are you asking generally or just when you're looking?
When you're looking.
I look at the Macca's packet. No. I don't think you can definitively say. So that's why you just say it's distended.
Yeah, so if you're reporting back as you go, and then on the larger side, would you say they're
Okay, no, I see what you're saying. Yeah, no. You can always go for the, the patient has central adiposity, which is, because that, that is actually kind of the kind of more clinical way of saying if they are obviously obese, but yeah, I suppose you're right. Distended does indicate some sort of pathology as opposed to they've eaten too much. So I suppose if I had someone who was obese, I would probably say, central adiposity and hope that they're not medically trained, which, Okay, so inspection. What else? So we've missed some other ones in inspection. Yes, exactly. And I definitely not expected to name them, but I suppose the two key ones, like if there's a big scar down the middle, you can just call that a midline laparotomy scar. Or the other very common one is laparoscopic scars, which is just 3 dots for keyhole surgery, laparoscopic surgery. So, yeah, look, they can have ones on the side for a kidney, ones at the back, like they can have other scars for open appendectomies, but that's, yeah, I don't think you're expected to recognize those scars. What perhaps is important is naming where the scar is. So what are our 9 quadrants, or no, 9 segments of the abdomen? Left and right. Yeah, exactly. Did everyone hear that? Do you want to?
You've got your epigastric, your hypochondriums, you've got lumbar, iliac, and then the umbilicus or periumbilical, and then the middle down is the hypogastric or the pubic.
All right. So, if you see a scar, you could just say, oh, there's a scar in the epigastric region or something like that. So scars, swelling, those are the main ones. I think I've got. And the dilated veins. I've never seen that. I think if you get to see that in a phase 1 OSCE, it'd be fantastic because you'd be like, oh, that's so interesting. All right, what's next after inspection? Light palpation. Fantastic. And how do you do it and why are you doing it?
Go around like the 9
Yep.
to like see if there's any pain, like really tender pain, so that's why you go light. And then you do like a little small like, turnaround pound.
Okay.
Don't tell me to do it, so like instead of just like going like that, you go like that's it.
Oh, okay, to actually okay. Yeah, so the idea is flat surface of your fingers. I mean, yeah, if you've been told just to give it a, press in a little bit, but what are you actually trying to elicit in light palpation? Yeah, pain and tenderness. So when you're actually feeling the abdomen, where do you look?
The face.
Yeah, looking at the patient's face. So in terms of palpation, I just say to the patient, okay, now I'm just going to press around on your tummy. Can you please let me know if it hurts anywhere? And then just go into doing it and watching their face as you do it for any signs of pain, wincing or anything like that. So you're feeling for tenderness. And then so what do you do after light palpation? Okay, and this is where the technique is kind of flexing at the MCP, so pressing in at the tummy, and what are you feeling for there?
Organomegaly or masses.
Yeah, organomegaly or masses. All right. So, yeah. Okay, what's next? Vincent, what's next? Okay. Have you been able to do percussion or palpation first for liver? Or doesn't matter?
My logic is if you percuss and know where the liver is, then you can palpate the liver. Although in the video they did do palpation before percussion.
Yeah, I think palpation before percussion is pretty standardized, so I would start with that. So how do we go about palpating for the liver? Yep. So firstly, before that, explain it. Okay. So how do you explain it to the patient? Because it's it does require a bit of cooperation. That's a kind of a funny thing to do if you step back and think about it. So how do you explain it to the patient? Mhm.
if there's any discomfort, then
Okay.
Breathe and keep breathing.
Yeah, so the breathing thing, yeah, that's the key thing. So just, take some deep breaths in for me. I'm just going to be moving my hand up your stomach, up your tummy, trying to feel for your liver. Yeah, so, and then you were saying before, you start at the,
iliac spine,
yep,
and then move all the way up to just below, as far as you can go.
yeah,
Yeah.
before you hit the costal margin. Now, and so you move your hand on inspiration or expiration.
Expiration. Oh wait, move. Wait. What kind of a move?
Oh, sorry, okay. When do you press in? Inspiration. And why is that?
The diaphragm pushing.
Perfect. You guys are on top of it. Yeah. And the idea is they say that you should get it, you should do no more than 6 deep breaths for the patient. That's just what they say, because I suppose if you are breathing deep for, too long, you kind of hyperventilate. So, yeah, up from the right iliac fossa and just moving the hand as you go. If you actually feel the liver edge, has anyone ever felt a liver edge in hospital? What? You felt it because the consultant told you it was there? Because that was my experience. Like, I've only kind of felt one, and it was only like, oh yeah, there's definitely one there. I couldn't really feel it.
Feel them callous?
So if you can feel it though, you can try and comment on the texture, but I really, as I said, I've only kind of felt one liver, so I wouldn't worry too much. And then percussion, how do you percuss the liver, for the liver? Are you percussing for the liver or liver? Yeah, so you can calculate the normal size of the liver. 8 to 12, exactly. Yeah, so, and what's the process for percussing for the liver?
Bottom up and then top down.
Yep, exactly. So where do you start for both ones? Yep, mid-clavicular line, so starting right iliac fossa, and then down from the second, I think third rib space is generally, or second or third rib space is generally accepted. Yeah, okay. Good. That's the liver. What's next? Spleen, how do we go about the spleen?
Right. Your eye actually also to like left, like order.
Yep, exactly.
And, like, technique.
And so you do that with your right hand. What do you do with your left hand?
You like hold it.
Yeah, so you're holding here, and then you're feeling up here. Go.
What's the angle called in the back where you're supposed to put
The renal angle,
renal angle, right?
like between the ribs and the spine.
Yeah.
Renal angle. Well, that is kind of the loin area. So did everyone get that, what we're talking about? Some people talk about the renal angle or the loin. That's the angle. So if you think about, you've got your spine and then the ribs are angled down as they come around. The angle is that angle between the ribs and the spine. So it'd be like that. This is the renal angle. So
Is it from like the muscles? Like muscles in the ribs? I don't know. For some reason
What-
I thought that it was like the big, the chunky, whatever the like ones that across from them and then the it's like if you because like for like
well, the renal angle is more just kind of like a surface anatomy. Yeah, so it's just because I suppose that's where the kind of kidneys sit if you're looking from behind. So whether it's from the muscles or not, like it's more a surface anatomy thing. So does that answer?
right, yeah. No, because like I don't know, so like someone told me to like put like I think for the ballotting or something.
Yes.
You like have to put your hand like right next to the muscles but underneath the ribs, and they said that was the renal angle. Because like if you put you can't like hit the muscles up too much.
Right next to the muscles, but underneath the ribs.
So it's just like a little bit more lateral to like the spine.
Oh, okay. I think I know what you're saying. because you.
Yeah. So like
We'll get to the kidneys in a second. We'll come back to that. So just for the spleen, so your hand, I mean, yes, kind of technically in the renal angle, but just essentially on their left side, and then feeling up from the right iliac fossa. Now this is when they're lying flat. If you can't feel it, you should offer to kind of like the examiner, would you like me to position the patient in the what position? Sorry?
Towards your right.
So right lateral, yeah. So just moving them onto there. So I'm now lying on my right side. The idea is that makes the spleen a little bit more prominent, and then you do it again. But again, that's one of those things, ask the examiner first. So that's the spleen. And then, yes, we get to the kidney. So can someone talk me through the kidney? So I'm just aware we're almost at time. Yeah, what do we do for the kidneys? What's the process of feeling for the kidneys? Blotting or bimanual palpation. So how do we do it? Can someone, or do you want to describe how you would do it, Mark?
So like you place your one of your hands like one of the hands on like the renal in the renal ankle.
Mm-hmm.
So like left, so like lateral to like the big muscle.
Yep.
Runs up and down, and then underneath the ribs, and then like you press deep with your other hand like from the front, and then like you try to like gently like flip it up.
Yeah. So, yeah, very good. I understand what you're saying now. If you feel it at your back, kind of quite immediately adjacent to your spine, there it's quite firm, and that is I think it's the erector spinae muscles. Well, you guys are doing AA, so you should. Oh no, do you do the spinal one? Anyway, but you can feel like then if you go a little bit more adjacent, it's quite fleshy there, and that's where you want to be putting your hand at the back. So blotting for kidneys, one hand at the back in that fleshy bit, and then one hand at the front, just kind of like underneath the ribs, again in that fleshy part at the front. And the idea is you're actually trying to like catch the kidney between your two hands. So you should be pressing up at the back and then pressing down here at the front at the same time to try and catch the kidney. Yeah, it sounds funny. So you do it one side and you do it the other side. So that's like in terms of that technique, that's something you need to practice. Just shifting your hands like left and right. Can you actually feel it? I've never felt a normal kidney, but they say like in really thin people you can feel it, or obviously if it is enlarged. But again, you're not expected to detect that. I think that was, yeah, no, so it's just pushing up at the back and then feeling.
So with reporting back with the abdo exam, if you're not really meant to feel anything, should you just say cut, upon blotting, kidneys cannot be felt?
Yeah, that's exactly what I'd say. So as I was going along, I did like for the kidney part of it, like I just explained to the patient, okay, could you please do this now and do that, and then I just say to the examiner, kidney is not blottable.
Okay.
Yeah. Yeah. So that is kidneys, and then after kidneys, what's next? Percussion. Yeah. Inspect, palpate, auscultate, then percuss, then auscultate. So percussion. So you do a general percussion around. Again, that's kind of feeling for a little bit of tenderness and just gives you an idea of like what the abdomen sounds like. And then, yes, so you percuss for ascites. So how do we do that?
Midline to where it sounds dull.
Yep.
And then if it's like abnormally central or like
Yep.
abnormally medial, then you get them to roll to the like other side.
Yes. Yeah, exactly. So the important thing is your finger needs to be vertical while you're doing that, because if it's horizontal, you can't tell the point at which it becomes dull. It should normally become dull like at the flanks. So if you're going around here and it becomes dull here, there's no kind of point asking the patient to turn around or turn on their side. But again, so percuss out to the point where it becomes dull, and if it does become dull, you would probably then ask the examiner, would you like me to perform shifting dullness? They'll say maybe yes, and then you ask the patient to turn on their side. Ideally, you wait for 30 seconds to allow any fluid to settle, but you probably don't have 30 seconds spare at this point in the OSCE. And then percuss again. If you say, if what was previously dull has become resonant, you say, yeah, shifting dullness is present. Does that make sense to everyone? Any questions on that?
For palpations, though, would it be appropriate to do AAA palpation?
That depends. Have they mentioned that in your classes?
I think it might have been just hospital.
Yeah, did everyone hear that? AAA, do people know what we're talking about? Abdominal aortic aneurysm. So obviously the aorta is running through the abdomen. Yeah. If there's a big aneurysm there, yes, you can feel it. You have to feel it in a particular way, though. I would advise against doing that in the gastro exam at the phase 1 OSCE level. Okay, so we've done shifting dullness. Yes, then we auscultate. What are we auscultating for?
Bowel sounds.
Bowel sounds, very good.
And bruise in the renal artery.
Bruise in the, yeah, you can, you can listen in the kind of midline for the abdominal aorta, and then kind of, essentially like 1 centimeter either side of the belly button or umbilicus for the renal bruise. And then for bowel sounds, so to say a bowel sound is actually absent. So I think actually can we all hear bowel sound? Like, do people, because I think bowel sounds, most people can hear them, or most people have them pretty regularly, and so you can hear them. If you actually can't hear anything, you technically have to wait. Some people say 30 seconds, some people say like 2 minutes. You have to wait that long before you can actually say bowel sounds are absent. Obviously, you don't have that time in the exam, so you just say, to the examiner, I can't hear any bowel sounds. Just report what you hear, kind of thing. But don't necessarily say that bowel sounds are absent. But you should hear.
Risk of asking a dumb question. Say, when we had a patient once who had lost their appetite, so they weren't eating, would you still expect bowel sounds in someone who's not eating?
Yes, because of the
Motility.
Yes, yeah, exactly. You're right. Depends how long they'd stopped eating for. I mean, maybe for like a week.
Yeah.
But normally you should expect bowel sounds, unless there is obviously a pathology. All right, I'm very mindful that I think it's right on midday. So, dullness, auscultate, and then just finishing up. Thank the patient, ask them if they need help getting back into their clothes, and then you speak to the examiner. Just for summarising, one of those tricky skills, I still struggle with it a lot, but it just comes through practice, and don't neglect it when you are doing your practice with your friends. So I suppose I just try and do it in like 3 big blocks. So I introduce, this is Bruce, 62-year-old male, who's coming with sharp central abdominal pain, woke him up at 3 a.m., kind of describe the presenting complaint. Further history reveals that he has a, 25, or drinks 25 standards a night or something like that. A bit more about his context, maybe medications that he's on. Only stuff that's relevant. I wouldn't go through the entire history. And then for the examination, again, you can kind of practice this for the phase 1 OSCEs. So I just normally would start off by saying, I then performed a abdominal examination on Bruce. It was a normal examination. Salient findings were, abdomen was soft and non-tender. Liver was not palpable. 10 centimeter span. Kidneys not palpable. Spleen, no splenomegaly. Just go through kind of the relevant negatives. And then you can always say, to complete the examination. Now for gastro, to complete the examination, you have to perform a genitourinary exam, and a perorectal exam, and an inguinal exam. So that's it. So the big thing that we obviously didn't do today is actually practice, but I didn't think that was kind of feasible in this setting. So, but that is, I know that, as I said before, it can be stressful to think that you have to practice alongside all the other study that you have to do. But I really recommend it just that 2 hours a week, set aside some time, and come the actual November is when your exams are, you'll be thanking yourself for it. So yeah, any final questions or comments? No? Okay, and I'll post the slides, of course. Thanks so much. Thank you so much. Oh, so it's a bit over time.
Oh no, it's okay.